Hello and welcome everyone to the PDCET 2024 OBGY crash course series, and today is the lecture 1 of this series, and you can subscribe this channel for more videos in the coming time. So we are starting this series just to help you by giving few important topics and one-liners and few previous year questions. So this will be a quick revision series only. You all have already passed your diploma exam, so you have a good command over the subject. And the good thing is that in PDCET only you have to read OB/GY, Obs and Gynae. No other subject is required. So you already have mastery in this subject. But the thing is that you all are already working now, and since last 2-3 years you have not given any MCQ exam. So the pattern is a bit different. In the diploma days you are more familiar with theoretical exams or clinical presentations, but now you have to again practice the MCQs. So less than 1 month time is left. So we will try to give more and more lectures to you, and will present lectures in a short period of time. So amniocentesis, first topic, culture of desquamated fetal cells in the amniotic fluid, and chromosomal study is done of the desquamated fetal cells in the amniotic fluid. So what is amniocentesis? We do culture of desquamated fetal cells in the amniotic fluid, and chromosomal study is done by the desquamated fetal cells. From fetal serum AFP is 150 times that of maternal serum. So in fetal serum the AFP level is more than that of the maternal serum. So acetylcholinesterase level in amniotic fluid is more specific than AFP in predicting NTDs. This is an important question, that which is more specific for predicting neural tube defects in amniotic fluid. So acetylcholinesterase is more specific as compared to alpha-fetoprotein. So therapeutic indications of amniocentesis in first half of pregnancy: induction of abortion, we give hypertonic saline, urea and prostaglandins; repeated decompression of uterus in acute hydramnios. And in second half of pregnancy, what are the indication of amniocentesis? Decompression of uterus in chronic hydramnios and intrauterine fetal transfusion in RH isoimmunization. Now site of amniocentesis in early months and in later months site differ. In early months 1/3 of the way up to uterus from symphysis pubis. In later months different sites can be there: transisthmic suprapubic approach after lifting the presenting part, and through the flanks between the fetal limbs, and below the umbilicus behind the neck of the fetus. So how question can be framed? That it can be given that which of the following is the preferred site for amniocentesis in early months of pregnancy. So these 4 points can be given in options, and you have to choose that the 1/3 of the way up to the uterus from symphysis pubis is preferred site for amniocentesis in early months of pregnancy. So while going through these videos and slides, you have to keep in mind that how MCQs can be framed. So now 22 gauge spinal needle is used. Amount to be collected is 10 ml. Length of needle is 4 inch to 10 centimeter. And precautions which are to be taken while amniocentesis: prior USG localization of placenta to prevent bleeding, and prophylaxis is given. 100 microgram of anti-D immunoglobulin in RH negative non-immunized mother is to be given. Now complications of amniocentesis: maternal and fetal. Maternal infection, hemorrhage can occur, premature rupture of membrane and premature labor, while in fetal trauma then feto-maternal hemorrhage are the known complications. Now what are the causes of elevated AFP? Many times in different exams questions have been asked that which of the following is the cause of elevated LFE, or which of the following is not the cause of elevated AFP. So causes of elevated maternal serum alpha-fetoprotein: neural tube defects, open abdominal wall defects like omphalocele or gastrostosis, and aneuploidy, renal disease, congenital nephrosis, infantile polycystic kidney disease, renal agenesis, that is bilateral, skin disease, ectodermal dysplasia or aplasia cutis, cystic adenoma, malformation of the lungs, maternal hepatic and ovarian tumors, uterine and placental anomalies, multiple gestation, feto-maternal hemorrhage, and fetal demise. So these all are the important points of elevated causes of elevated alpha-fetoprotein in maternal serum. Now important one is that just remember causes of decreased maternal serum alpha-fetoprotein. The list of increased is more, but the decrease only few. So Down syndrome, very important one. Many times questions have been asked. Cystic fibrosis, very important. So these two are the important causes of decreased maternal serum alpha-fetoprotein. Other are hydrocephalus, increased maternal weight, and overestimated gestational age. Now prenatal screening. Now just a minute, how question can be framed here: that which of the following is not a cause of increased maternal serum alpha-fetoprotein, or which of the following are the causes of increased maternal serum alpha-fetoprotein except. So 3 options will be from the previous slide, and one option will be like Down syndrome, so you have to choose this one as a cause of decreased maternal serum alpha-fetoprotein. Now, prenatal screening, triple test and quadruple test. These are the two important prenatal screening tests. Triple test include HCG, estriol and alpha-fetoprotein, maternal, and quadruple test includes AFP, HCG, estriol, and we add inhibin A as another parameter in quadruple test. This is the protocol for quadruple test. Dating ultrasound 16-18 weeks. Confirm gestational age, rule out multiple pregnancies, rule out fetal demise, and maternal serum drawn at 16 to 16 weeks. So if negative, then alpha risk of down is very less, so no further testing is required. If it's positive, if the alpha-fetoprotein in maternal serum is decreased, do ultrasound if not already done. If date is correct, counseling with regarding to amniocentesis, and if date is incorrect, then test done. If the test was done at less than 15 weeks, then repeat test at 16 weeks. If test was done at more than 15 weeks, then calculate the risk of Down syndrome. Now if maternal serum alpha-fetoprotein is increased, then what risks are there? Anencephaly and open spinal defects, ultrasound is done. If fetal age and anomalies are to be scanned, and if it's normal, then counsel about the risk. Now this table very important. Different three important anomalies: neural tube defect, trisomy 21 and trisomy 18, and the value of AFP, HCG, and estriol in these conditions. So in NTD, only AFP is increased while other two are normal. In trisomy 21, both decreases, only HCG increases. In trisomy 18, all the three parameters decreases. So remember this table, questions can be formed easily. Other topic is coronary villus sampling. Transcervical it is done at 10 to 12 weeks, while transabdominal it can be done from 10 weeks to term. Now, important question: what happens if it's done before 10 weeks? It can result in oromandibular defect. So, risk of which now the following is increased if CVS is done before 10 weeks. So option will be oromandibular defects, and you have to choose that one. Slightly higher risk of fetal loss is there in CVS. So now difference between CVS, amniocentesis, and chordocentesis. Timing: transcervical CVS is done in 10 to 13 weeks. Transabdominal is done as 10 weeks to terms. Amniocentesis after 15 weeks, and if early is to be done, then done between 12 to 14 weeks. Chordocentesis is done at the later stage, 18 to 20 weeks. Now, what material is taken for studies in CVS? Trophoblast cells are taken. In amniocentesis, fetal fibroblast is taken. In chordocentesis, fetal WBC by puncturing umbilical vein is taken. So question can be framed that fetal WBC by puncturing umbilical vein is done in which process? Option will be chordocentesis, amniocentesis, CVS. So answer will be chordocentesis. Now causes of oligo and poly. Oligo AFL less than 5, polyhydramnios. So the causes of oligo are renal agenesis, multicystic dysplastic kidney, amnion nodism, IUGR, post maturity, prom, and post urethral valves. While polyhydramnios, these are the important causes: esophageal atresia, duodenal atresia, diabetes mellitus, multiple pregnancy, open entities. So how question will be framed? Which of the following the causes of oligohydramnios accept? So three options will be from this table, and one of them will be from this table, so you have to choose appropriately. Now about Doppler flow: peak velocity of blood flow occurs during systole, and a small amount of blood flow occurs during diastole. So systolic to diastolic ratio is used for assessment. Now abnormal flows: absence flow can be there, reversal of flow can be there, and notching of waveform from at end of systole can be there. What are the causes of abnormal flow? IUGR, fetal distress. Now peak systolic flow is designated as S, peak diastolic flow as D, mean volume as M. So these can be asked, what is pulsatility index? So S minus D upon M. What is resistance index? S minus D upon S. So MCQ can be given, they can give values of these three, and they can ask to calculate either pulsatility index or resistance index. So in normal pregnancy, what happens? S by D ratio, pulsatility index and resistance index decreases with gestational age. Okay, so good numerical MCQ can be also formed, and interpretation can be asked. So now serial fetal MCA velocity monitoring is used to assessment of fetal anemia. In case of fetal anemia, what is done? Serial fetal MCA velocity monitoring is done. Diastolic notch on uterine artery Doppler disappears by 22 weeks. So when diastolic notch disappears on uterine artery Doppler by 22 weeks, if it persists, then it's predictor of preeclampsia. So which of the following are the predictor of preeclampsia? The persistence of diastolic notch on uterine artery Doppler after 22 weeks of gestation is predictor of preeclampsia. Now other one is CRL, crown rump length, parameter to calculate gestational age in first trimester. Now question can be asked, CRL is used to calculate gestational age in first, second, third or all. So in first trimester, linear measure of the longest axis. Usually 3 images are taken on USG and maximum length is used as CRL. So CRL at 1 month is 5 mm, 2 months is 30 mm and full term it's 300 mm. Changes in normal pregnancy, hemodynamic changes. What important hemodynamic changes? Increased cardiac output, blood volume, plasma volume and pulse rate. So these 4 parameters increase. Compression of SVC causes supine hypotension syndrome in third trimester. So what is the cause of supine hypotension syndrome in third trimester pregnancy? Compression of SVC, IVC, left atrium, right atrium. So compression of SVC, superior vena cava, causes supine hypotension syndrome in third trimester. And decreased pulmonary vascular resistance, peripheral vascular resistance, pulmonary vascular resistance and arterial BP. So these 3 parameters decreases, these important parameters increases in pregnancy. Now skin changes, increased pigmentation of areola, chloasma seen, linea nigra on abdomen, spider angioma, palmar erythema, stria gravidarum. These are normal skin changes seen. What are respiratory changes? Decrease of total lung capacity, functional residual capacity and residual volume, while increase of tidal volume, minute volume and oxygen requirement. So these important questions, which are the following decreases in pregnancy except? So TLC, FRC, RV and TB. So TB will be the answer. So you have to remember which respiratory parameter decreases in pregnancy and which increases in pregnancy. About genitourinary tract, increased urinary frequency is seen, and increase UTI, chances of UTI increase, and glycosuria can be seen in pregnancy. Other changes: increased incidence of CTS, that is carpal tunnel syndrome, median nerve entrapment, increased thyroxine and thyroxine binding globulin levels, and normal TSH, gallstone GARD can be seen, and increase renal blood flow and glomerular filtration rate. So this can be asked, what happens to RBF, renal blood flow and glomerular filtration rate in pregnancy? So it increases. Okay. Now predominant controllers of fetal growth. Which are the important controllers of fetal growth? IGF-1, insulin and growth factors. Pregnancy causes increased concentration of globulin, fibrinogen, transferrin and leukotrienes. Signs of pregnancy, few important signs. MCQs have been asked in past many times. Chadwick sign. What is Chadwick sign? Congestion of pelvis causing blue or purple hue of vagina. This is Chadwick sign. Leukorrhea, non-firm pattern of cervical mucus. Goodell sign, cyanosis and softening of cervix. Good, soft. So remember in this pattern. So Goodell sign, cyanosis and softening of cervix. Hagar sign, compressibility of isthmus on bimanual examination is Hagar sign. What is McDonald sign? Uterus becomes flexible at uterocervical junction. Flexible at uterocervical junction is McDonald sign. So von Fornix-Sedwell sign, irregular softening of fundus at site of implantation. Piscasek sign, softening of cervix with lateral implantation. Osiander sign, pulsation of lateral vaginal fornix is seen. So this is Osiander sign. Just remember these signs easily, they can frame MCQ. What is Palmer sign? Rhythmic contraction of uterus is Palmer sign. So how you measure or how you appreciate contraction of uterus? By keeping your palm. This is your palm. So this is Palmer sign. Now Winberg sign, abdominal pregnancy. So Winberg sign is seen in abdominal pregnancy. Now progesterone levels, low levels seen in ectopic pregnancy or abortion, high levels is seen in H-mole and iris immunization. So other is umbilical coiling index. So these, each and every slide contains MCQ questions, so go through them properly. So umbilical coiling index on USG, number of coils per centimeter of umbilical cord per centimeter. Okay, number of coils per centimeter. Normal is 0.17 coil per centimeter. Hypocoiling if it's less than 0.07, and hypocoiling is associated with fetal death. Hypercoiling more than 0.3 coils per this is less than 0.07, this is more than 0.3, so associated with IUGR or fetal acidosis. Hypercoiling. Absolute positive signs of pregnancy. Which are the absolute positive signs of pregnancy? Palpation of fetal part and perception of fetal movement by examiner around 20 weeks. Auscultation of a fetal heart sound. USG evidence of embryo at 6 weeks and later on fetus. X-ray evidence of fetal skeletal shadow by 16 weeks. So this can be asked. X-ray evidence of fetal skeletal shadow is absolute positive sign of pregnancy after how many weeks of gestation? So after 16 weeks. Probable manifestation of pregnancy: abdominal enlargement, uterine contraction. Painless uterine contraction is known as Braxton Hicks contraction, uterine ballotment, and uterine shuffle. Antepartum fetal monitoring, non-stress test. This is an important topic. Antepartum fetal monitoring, non-stress test. How it's done? What is non-stress test? Continuous electric monitoring of fetal heart rate along with recording of fetal movements is noted. So it is not cardiotocography. NST should begin at 30 weeks and is done bi-weekly. Normal or reactive test is, so what is normal and reactive NST? 2 or more than equal to 15 beats per minute acceleration over baseline of the FHR that lasts more than equal to 15 seconds during a 20 minutes period. So this line is very important. What is normal or reactive NST? 2 or more accelerations of more than equal to 15 beats per minute over baseline of the FHR that lasts more than equal to 15 seconds during a 20 minutes period. Okay, remember this properly. You monitor for 20 minutes. In that 20 minutes, if the baseline heart rate was 130, then more than equal to 15, that is that we have to see acceleration. So acceleration up to 145, and it lasts for more than equal to 15 seconds. So these all are the parameters for this. If NST is non-reactive, abnormal, then BPP should be done. Biophysical profile: NST has false positive rate of 50% and false negative rate of 0.5%. Non-reactive NST can be due to, important point, fetal sleep cycle, gestation age less than 30 weeks, fetal CNS anomaly, or maternal sedative or narcotic use. Now this is biophysical profile. You all know, you all have read many times. So what are the variables? Fetal breathing movement, cross body movement, fetal tone, reactive fetal heart rate, qualitative amniotic fluid volume. And normal score 2 is given. If abnormal, then 0 score is given. So fetal breathing movements more than equal to 1 episode in 30 minutes, each lasting more than 30 seconds. It's absent or no episode of more than 30 seconds is seen in 30-minute period. Gross body movement: 3 or more discrete body or limb movements in 30 minutes. Episodes of active movements is a single movement. Less than 3 episodes is seen in 30 minutes, so it's abnormal. Fetal tone: more than 1 episode of active extension which return to flexion of fetal limbs or trunk. Opening and closing of hand is considered normal. A slow extension with return to flexion movement of limb in full extension of fetal abnormal movements. Fetal movement absent. Reactive fetal heart rate we have already discussed in the previous slide. Quantitative amniotic fluid volume: more than one pocket of fluid measuring more than 1 centimeter in two perpendicular planes, and pockets absent or pocket less than 1 centimeter in two perpendicular planes. The important thing is how to interpret. Normal is 8 to 10 if amniotic fluid index is adequate, and CNS is functional and fetus is not hypoxic. Equivocal, if score is 6, and if less than 4, this is abnormal. And along with oligohydramnios, labor induction. If the BPP is less than 4 and oligo is present, then labor induction is to be done. The BPP is also known as Manning's score. Indication of BPPV is non-reactive NST or high-risk pregnancy. Modified BPPV is NST plus amniotic fluid index, used when NST is non-reactive and AFI is less than 5. Now pseudocysis: patient with intense desire of pregnancy and develops pregnancy symptoms of pregnancy. No fetal heart sound is there, no UHD documentation, just lag, but the patient feels symptoms of pregnancy. So this is pseudocysis. Now X-ray evidence of fetal death. What are these important signs? Spalding sign: overlapping of skull bones. Roberts sign is gas in aorta. Increased curvature of fetal span can be seen, and angulation of span can be seen. So these all MCQs question have been asked in previous year exams, anywhere in any of the medical entrance exams. So Spalding sign, overlapping of skull bones. Roberts sign is gas in aorta. Fetal, now here how question will be framed, you know well, that which of the following is not X-ray evidence of or not the sign of fetal death in X-rays. Option is Spalding sign, Roberts sign, increased curvature of fetal spine, and any other option will be there. So this way MCQ can be framed. Fetal hematopoiesis: structure and period of hematopoiesis. So yolk sac is the first site. Question can be asked, is the first site of hematopoiesis in fetus. So yolk sac. Period is 16th day of life to 8 weeks. Aorta, gonad, mesonephros 23 to 40 day. Liver comes into action at 5 weeks to term, and of bone marrow 8 weeks onwards. Term and adulthood fully established by 28 to 30 weeks. So 28 to 30 weeks is important, that bone marrow hematopoiesis is established by 28 to 30 weeks. Now cardiotocography: recording of fetal heart rate and uterine contractions. Machine uses electronic fetal monitor. Now fetal heart rate deceleration, early deceleration, variable deceleration, late deceleration, and uterine. This what you have to do. This is uterine contraction, and you have to assess the heart rate, fetal heart rate, with comparison to the contraction of uterus. So different types of deceleration are there, and description and cause and treatment. So early deceleration, type 1 dips, deceleration begins and ends with uterine contractions. Deceleration, early deceleration. So deceleration begins and ends with uterine contraction. Early deceleration, this is deceleration begins with uterine, here contraction is there. So with uterine contraction, deceleration begins and ends with uterine contractions. And the cause is important. Questions have been framed from here only. Due to fetal head compression and vagal activation, so no treatment is required. Late deceleration is type 2 dips. Deceleration begins after uterine contractions and persists until after contraction is finished. So late deceleration, this is uterine contraction, and deceleration is begin after uterine contraction. So this is late. So it indicates fetal hypoxia and chronic uteroplacental insufficiency. If late deceleration are recurrent, immediate delivery is necessary. So late deceleration is immediate delivery is necessary. Now variable deceleration, inconsistent onset, duration and degree of deceleration that disappears with change in position of the patient. Now what are the causes of variable deceleration? Umbilical cord compression with change of mother position, deceleration disappears. Antenatal USG parameters, CRL is used in first trimester, biparatal diameter is used in second trimester, and femur length is used in third trimester. So these are antenatal USG parameters as per the trimester of pregnancy. Abdominal circumference is best parameter for assessment of fetal growth and fetal nutrition. Best parameter to detect IUGR and macrosomia. Abdominal circumference more than 37 indicates more than 35 centimeter indicates macrosomia. These all are questions. Now fetal skull, anteroposterior diameter of fetal skull, remember this table. Suboccipitobregmatic 9.5 centimeter, suboccipitofrontal 10 centimeter, occipitofrontal is important 11.5 centimeter, mantovertical 13.5 and submantovertical 11.5, submantobregmatic is 9.5. So the longest is mantovertical, that is 13.5. So engaging diameter, attitude of head and presentation. Engaging diameter is suboccipitobregmatic in complete flexion of head, and the presentation is vertex. Submantobregmatic, complete extension of head, presentation is, if the head is completely extended, then presentation will be face definitely. Mantovertical, longest diameter, partial extension, and row presentation is there. So this table is very important. You just remember engaging diameter, attitude of head, and presentation. Transverse diameters, biparatal diameter 9.5 centimeter. Widest transverse diameter is biparatal diameter. This diameter always engages whatever be the position of the head. So which diameter always engages whatever be the position of head? So it's biparatal diameter, and this is the widest transverse diameter. Bimastoid diameter is 7.5 centimeters. Narrowest diameter of fetal scale, it's incompressible. These all are important points. A type of pelvis, image based question can be asked. This is gynecoid, platypeloid, android, and anthropoid. 4 types of pelvis are there. So type of pelvis and comments. What is gynecoid or round pelvis? Its most common type of pelvis is gynecoid or round pelvis. See, gyne means related to female. So pelvis of female, most common is gynecoid only, known as female pelvis. Wide subpubic angles, normal vaginal delivery without any difficulty occurs in this case. Anthropoid or anterior posterior part is oval. AP diameter is more than transfer diameter in anthropoid. Non-rotation is common. Phase to pubis delivery occurs. Android or triangular or heart shaped, known as male pelvis. Android is male. So narrow subpubic angle, delayed engagement, deep transverse arrest is common in android pelvis. These all MCQ questions can be asked. This table is very important. Difficult instrument delivery occurs, so perineal tear occurs. Platypeloid, flat bowel like, transversely oval, least common. This is least common. This was most common. Gynecoid and platypeloid is least common. Very wide subpubic angles, head engages with marked asynclitism. So these are important points about the different types of pelvis. Now diameter of pelvic inlet, anterior posterior is true conjugate. Okay, so extension is from the sacral promontory, superior margin of pubic symphysis, diameter is 11.5. So anteroposterior true conjugate diameter is 11.5, diagonal conjugate 12, obstetric conjugate 10.5, transverse diameter 13.5. Obstetric conjugate is important. It's from sacral promontory, nearest point on posterior surface of pubic symphysis, and its diameter is 10.5 centimeter. So this was a short class today. So for more such videos you can subscribe this channel. Thank you for your patience. Try to read at least few hours a day and try to solve MCQs as much as possible. Thank you.